My name is Felipe Lopes. I'm from Portugal. My clinic is in Porto. And I'm here today to this webinar series is going to be about immediate implant placement. So basically, all I'm going to be talking about is immediate load made easy for all clinicians. I'll be talking about really flapless surgery and all the rationale behind doing flapless surgery, what can be a very a plus in your clinical practice. Well, first of all, we should understand why most of the time we can go flapless and also do immediate load, because there's a lot of cases that people are afraid to go for flapless and to do immediate load. So if you understand that, and if you learn all the flow, the workflow that is needed, you'll be able to do immediate load in almost every of your cases. Almost, I would say above 90% of the cases. So let me show you this end result. This is more than 2 years post-op. And what you're doing is you're not looking at the implants, okay? This is the multi-unit abutments, not the implant connection. And this was done on all 4 upper incisors. And this was flapless, no GBR, with immediate load and everything. And the starting point was this. So this was a tooth mobility grade 2 and 3, a Miller 2 and 3, and we could reach this end result. Later on, we will see this case step by step. Okay, so you can really reach absolutely amazing results. This is the end result, 26 months post-op, and you had a periodontal patient. You had a very difficult case to treat, and you did no GBR, no flaps, and this is absolutely, it took you just 5 months to reach this destination, to reach this end result. Just in 5 months, you were able to absolutely treat in a very beautiful way this periodontal patient with a severe condition. So that's what we're going to try to talk about. So this course, this webinar course, this will have special highlights on socket shielding techniques, or partial extraction therapies, as you can call it, and chairside provisionals for single crowns, how you can do it. We'll go through a thorough step-by-step procedure so that you can understand it and you can implement it on next Monday in your office. And also a simple digital flow for lab provisionals, because nowadays it's so much more important that you get your hands into the digital tools that we have to ease your job, to ease your work and provide your patients with better results. Well, these 4 webinars, the first one, which is this one, will be about the post-extraction socket, because it's very important that we can understand that. That's the way you will reach this end result in such a small amount of time. And also, the second webinar will be about immediate implant placement. Once we have understood the post-extraction socket, well, there is a rationale, there is the science behind being able to immediately place implants in the extraction sockets. Also, socket shield. We are going to talk about several partial extraction therapies and how you can reverse socket shield. I call it reverse PET, reverse partial extraction therapies, so that every clinician can do it so much easier in such a much more easier way than it was before. And also, the last webinar will be about provisionals, because it's so important. Will be about immediate load, how you can go to provisionals or even final restorations, and all the digital flow that will be accurately displayed and showed to you, all the digital flow that will take you there. So let's start off with our first webinar. We're going to be talking about post-extraction socket. We're going to be talking about healing biology of the post-extraction socket, because it's so very important that you understand how soft tissues and bone behaves after you extract a tooth. And also, one of the topics will be the buccal plate dimensions, because it's very, very important that you are aware of it and how that impacts your treatment. And so we're going to be a little bit through the buccal plate dimensions in the populations, and also the bone biotype. And we'll relate it to immediate implant placement. And one of the most important things when you're talking about immediate implant placement is to establish your socket type. This is a key issue, because it's a simple, fast way for you to establish the difficulty of your case and to implement the strategies that you need to solve it. So this three topics will be the essence of the webinar here today. So let's start off with the healing biology, because it's very, very important. When you have a socket, when you extract a tooth, you should ask yourself, what happens to the adjacent tissues? What are the adjacent tissues? We have epithelium, we have connective tissue, and also we have bone. We are very obsessed about bone, but it's just not bone, not only bone. So we should take care of a lot more than that, and try to understand the biology of all those three tissues that are involved in immediate implant placement, and they are involved in the healing of a post-extraction socket. So what were we taught at the university, and why is it true? Because what we were taught was that if you had a post-extraction gap, the thing is, you would probably get, if it was over 0.5, even some authors would say that in between 0.5 and 1.5 millimeters of a gap, you would have fibrous tissue ingrowth. And you have a lot of literature supporting this. So one of the enemies would be fibrous tissue ingrowth when you're doing immediate implant, and an immediate implant, and you're placing it into the socket. And you have Akimoto's article, and it was in dogs, but you could clearly see that it was when the gap was around 0.5, 1.5 millimeters, you would really get fibrous tissue ingrowth, something that you don't want to, because you want to have bone growth against your implant. So what had all these studies in common? Because they had something in common. And what they had in common was that every surgery that was described in this studies was done under primary closure. And as surgeons, thing is, we love primary closure. We love to have our wounds primary closed almost every time. But what's wrong with primary closure? Thing is that the blood supply to the buccal bone and to the socket comes from three sources. Okay, We have the periosteum, as you well know, we have the bone marrow, and also the periodontal ligament. So many things are wrong with primary closure, and let me just list some of them. So once you're trying to do primary closure, you got to flap. So you sever periosteum. By flapping, by raising a flap, you're severing the periosteum. By doing so, you're exposing the buccal plate to resorption. Also, one of the greatest disadvantages of primary closure is that you're displacing the mucogingival junction to the aesthetic area because you're trying to close the wound. You have a buccal flap. As you displace it to achieve primary closure, well, you displace all the mucogingival junction to your aesthetic area. Also, wound borders come close to each other. We usually, as surgeons, and as oral surgeons, as I said, we love that the wound borders are close to each other. You can close it, really achieving primary closure. We'll talk a little bit about that later. And also, when you're trying to do primary closure, as you raise the flap, the pedicle flap that you've raised is now being nourished by the underlying connective tissue. So it will be capable to grow faster into the socket. And that's a key point, okay? We'll get back at this key point later on. Let's see. Primary closure, in fact, seems so innocuous and easy, so logical. It seems like the kind of way that we should try when we're doing immediate implant placement and when we do any kind of surgery to achieve primary closure. But what's wrong with severing periosteum? Because when you raise the flap, you always sever the periosteum, okay? And that's something that we should really know about. And to know something about it, you should listen to Molly Stevens. She's probably one of the biggest experts in the world in bone. So what's wrong? What happens to the periosteum? Let's see a little bit. I invite you to go to, she has a very, very nice TED Talk. And you could go to a TED Talk, to her TED Talk. You got this QR code. If you scan it, you go directly there, and you will learn a lot about bone just by listening to her and to see all her research. Let's hear just a little bit of Molly Stevens' TED Talk.
And it's an approach that we called the in vivo bioreactor, and we were able to make enormous amounts of bone using this approach. Cells on the outside of our long bones, that layer is called the periosteum, and that layer is actually normally very, very tightly bound to the underlying bone, and it's got stem cells in it. Those stem cells are really important in the embryo when it develops, and they also sort of wake up if you have a fracture to help you with repairing the bone.
So we take that periosteum layer
and we developed a way to inject underneath it a liquid that then within 30 seconds.
So the thing is, periosteum is so very important. So let's you could see what she said. You were able to produce bone if you didn't sever the periosteum. If you could just raise it without severing, and it's quite something, because the periosteum is very, very rich in stem cells that can be awakened to produce bone anytime that you want to. So next time you sever periosteum, you just think twice, because it could really be an issue, okay? So let's try to understand all the tissues involved in a tooth extraction, not only just bone, but epithelium, connective tissue, and bone. The thing is, when you extract a tooth, you have an alveolus, okay? If you don't flap, what's going to be happening is that you leave the connective tissue and the epithelium, you leave it alone. Something that you should also learn is that epithelium has no vascularization of itself. The vascularization of the epithelium depends on the vascular supply coming from the connective tissue. And this is a key issue also to understand the biology, the healing biology of the socket. So as you go through this, you can see that you have always epithelium overlying the connective tissue. And just don't forget, the epithelium vascular supply is depending on the connective tissue. In between bone and the soft tissues, you will have the periosteum. As we've seen from Molly Stevens, it's a very, very important layer of cells. So let's see what happens when we extract a tooth. The blood clot forms, okay? The epithelium has no vascularization of its own. Just remember that. So the blood clot forms, and the thing is, blood clot is made of dead cells, okay? So it's a kind of it's a granulation tissue that is forming from the bone walls and filling in all that blood clot. So the granulation tissue is the one that is providing the vascular supply for the epithelium to grow on top of our extraction. This is called contact inhibition. So this is why epithelium can't grow without the vascularization coming from the granulation tissue. So the epithelium will never grow into the socket. If you don't flap, the epithelium will never grow into the socket because of this contact inhibition. So that's why. That's why primary closure is so important. If you do primary closure, it will change everything. It's like a wound healing. You have a healing of, this crust. It's like the blood clot. It's dead cells, and you have the epithelium growing 1 millimeter a day under the crust. So it's a completely different thing if you flap. If you raise a flap, and that's something that you should be aware about. If you raise a flap, you're dramatically changing all the biology, all the healing biology of your socket. Because when you don't flap, when you don't raise the flap, the vascular supply from the granulation tissue formed inside the socket, that's what will ensure that the epithelium will slowly grow from the borders because of the contact inhibition, and it won't grow into the socket. That's why. So you will have bone into the socket because the epithelium will not be able to grow into the socket. But if you raise a flap, that's a completely different thing, because you will change the vascular supply. Why? How? That's your question. Because your vascular supply for the epithelium and for the connective tissue will not come from the granulation tissue anymore. It's not coming from there. It's coming from the connective tissue and flaps. So the connective tissue and the epithelium will grow into the socket instead of having bone growing into the socket, because you will eliminate the contact inhibition. You will change all the biology of healing. And one of the most important studies in this topic was from Dennis Tarnow and Stephen Chu. And they had the first immunohistological verification of an osseointegration and bone forming against an implant despite they had done an excessive gap, a bigger gap than ever before. So they placed this implant, and they left a gap, a very, very big gap. And after 8 months, or 9 months, I'm sorry, this was almost it was above 4 millimeters, the gap. And they could see on the CBCT that there was bone, or it seemed to be bone. They explanted the implant, and histology as proved, this was a proof of principle concept, has proved that you really had bone against your implant. No soft tissues and growth into the socket, despite there was a big, big gap. And in fact, let me show you a case. Sorry. Let me show you a case where you can see that. There's a molar area, you extract the tooth, you place an implant. Over there, there's a huge gap all around. All around, there's a huge gap from the extracted roots, from all of them. So you have a gap of more than 10 millimeters, I would say. So you would expect that fibrous tissue ingrowth could occur in here. Well, you can see a detail of healing, early healing. As time goes by, you can see that the soft tissues are healing. You can see also some buccal collapse, soft tissues still healing, and the buccal collapse is becoming bigger and bigger. So exposure day, okay, this is exposure day, and everything is healed, and you could expect, because there was a huge gap, you could expect fibrous tissue ingrowth. The thing is that when you open and you re-enter, you can see that you have bone. In some of the places, you have even bone on top of the covering screw. Even on top of the covering screw, you can have bone. And just a little detail, the little movie, when the implant was exposed, you can see those small, tiny little spicules of bone. It's really hard bone. So there was no tissue ingrowth. And why? Because you didn't flap. You didn't flap. Despite it was a molar area, a super big gap, yet it didn't have fibrous tissue ingrowth. So that's one of the biggest advantages of not flapping. Okay, that's the key message up until now. So we've been through a little bit about the healing biology of the post-extraction socket and some of the more relevant issues. Now let's see, take a look about the literature and about what we know about buccal plate dimensions and the population, and a little bit about bone biotype, and try to understand the impact of this in immediate implant placement. Okay, one of the key issues on bone and implant dentistry is that, as Wally Grunder and Boozer and Belser have stated for lots and lots of time and years of studies, and pretty well done studies, is that it's desirable that you have 2 millimeters of labial bone around an implant at the buccal. Okay, but what is really the minimum buccal plate thickness to provide for proper soft tissue support? Because the thing is, when we go to the studies that have been analyzing the buccal cortical plate, as this study from Nausari in 2012, it's evident that most of the patients have a thin facial bone, okay? Most of them, it was 97%. And other studies are Vedrana, Brow, Bornstein, Belser, Boozer, they've encountered just the same thing. So 90% of the patients, plus the 90% of the patients, would have thin facial bone walls. If we still go through the literature, Ryan Cook studies, well, pretty much the same. We have a thin facial bone wall in almost every of our patients. So the mean bone thickness in most of the people is well less than 1 millimeter, and not even to talk about 2 millimeters, because it's pretty much all of that. So when it comes to bone biotype, you have a thin bone biotype if you have a 0.34 millimeters and the thick 0.75. It's going to be thick, just 0.75, and this is because only 3% of the patients had a labial cortical plate that was around 2 millimeters, and only not even 5%, so less than 5%, 4.6% of the patients had a labial plate with more than 1 millimeter thickness. So 92% of all patients will have less than 2 millimeter of in what comes to buccal plate thickness. This is relevant. This is relevant because if you're thinking about placing implants and immediate implant placement, if you're thinking about placing implants into a post-extraction socket, you're starting to see that if you need around 2 millimeters of thickness, that's what they say, Grunder, Boozer, and Belser, well, to have a natural emergence profile, as you'll encounter difficulties in 92% of patients, you will need augmentation almost every single time. So to achieve a natural emergence profile, that's what these studies are telling us. You will probably need to augment all the time, or almost all the time. So, but will we really need augmentation all the time? That's my question. So to achieve this 2 millimeters labial bone, to achieve this natural emergence profile, we have basically two kind of strategies: non-grafting strategies and grafting strategies. That's what we should be designing in our minds now. So about non-grafting strategies, you must be able to do a traumatic tooth extraction, as traumatic as you can. And also, you should be obsessed by palatally positioning your implant. Position it to the palate. It's one of the most common errors, is to position your implant slightly to the buccal. So that's one of the things you should be obsessed about. And one of the things that you should know, you should also know, is that on the post-extraction socket, it's going to be a little bit more difficult for you to place your implant palatally, because the socket will almost always try to take you to the buccal. So you should be really focused on that, okay? So, and why are all this procedure needed? Because of bundle bone. Because of bundle bone. You know, bundle bone is all the bone that's related to the PDL, to the periodontal ligament. And the thing is that all that bone adjacent to the periodontal ligament, which we also call alveolar bone proper, that bone, once you extract a tooth, what happens to the buccal plate? Well, that region of the buccal plate, the buccal plate that is related, once you extract the tooth, you will have no periodontal ligament. So as it's so thin in most of our patients, and remember, it was above 90% of the population had a very, very thin labial plate. As you extract the periodontal ligament, it's one of the most important sources, vascular supply sources to the buccal plate. Well, it will be insufficiently nourished, and this will lead to its total or partial resorption, okay? Araujo and Linde, they showed that the periodontal ligament blood supply is it's one of the most important things when it comes to preventing the bone resorption of the buccal plate. So how can we achieve this? How can we make it better? Is there a way to make it better? Well, if you do a traumatic tooth extraction, if you do palatal positioning of your implant and immediate implant placement, well, you might go away with a non-grafting strategy, but also you should be considering in modern implant dentistry to preserve the periodontal ligament, and this is socket shielding, and partial extraction therapies. Maurice and Henry Salamo's studies on root submergence, they were actually one of the first, and also Herzler and Zurich studies. Well, they changed, I would say they changed implant dentistry forever. It's not going to be the same, never again. So that could prevent you to having to go to the grafting strategies. So it might be a way for you to avoid GBR soft tissue graft and even GBR and soft tissue graft, as you will have to do a lot of times if you're talking about conventional immediate implant placement. Many times it won't be enough for you to do a traumatic tooth extraction. If you really extract the entire tooth, many times also it won't be enough for you to have a palatal position of your implant, because the tissues will collapse. So many times if you're doing conventional tooth extraction, you will have most of the time to graft your site. Besides doing immediate implant placement, you will have to graft, do guided bone regeneration, do soft tissue grafting, and many times you will have to do both. And that's why maybe this idea of preserving, as we'll see along all the 4 webinar series, that maybe this idea of preserving the periodontal ligament will make sense and will make us able to provide our patients with a better treatment. So, all this being said, one of the most important things at time when you decide to go for immediate implant placements for this kind of procedures, and you want to be predictable, one of the things that you should know is to, in a simple, fast way, you must establish difficulties. How difficult is it going to be? Because not all the immediate implant placements are the same, okay? So you should be able to establish the difficulty, because that will allow you to also design a strategy in terms of your clinical action to solve your patient's problem. So one of the most important classifications ever was this one from Alien, Tarnow, and Shu in 2007. And they related the buccal bone location with the soft tissue location. And so they came up with 3 possibilities. You have type 1, type 2, and type 3. In type 1, you have the soft tissues are normal. So they are at a normal level, and also bone level is normal. You have no bone loss, okay? In type 2, you should be a little bit more careful, because in type 2, the soft tissues are normal. They have a normal level, okay? But if you go to the X-ray, if you go to the CT scan or the CBCT, you can see there's a bone loss. So these ones do ring some warning bells, okay? Type 2, they look normal at the site, but the thing is, when you go to the CBCT, you can see there's bone loss. Type 3 are easy. These are where the soft tissues match bone. So you have a tremendous bone loss, but also you have a tremendous soft tissue loss. So it's easy to diagnose that you have no tissues and no bone. So that'll be type 3. Thing is, type 2, as you could see, as I was telling you, type 2 is it's the trickiest one, okay? Because soft tissues do really look normal. There's a normal level of soft tissues. And they started to see that they had a different tooth, okay? Because you could have a slight bone resorption, a medium bone resorption, and you could have a huge bone resorption and still have normal soft tissues. So Shu and Tarnow in 2015, so 8 years later, you see that, 8 years later, they came up with a subclassification of type 2, because the type 2 is really a tricky one. You should be aware of this, and you should be always looking for type 2. Don't let yourself be wronged by type 2. So socket type 2, in socket type 2 you have a normal soft tissue location. Soft tissues do look normal. In 2A, you have almost a third of the buccal plate is gone. In 2B, half of it is gone. And in 2C, almost all of it is gone. So you should check these articles from Shu and Tarnow, 2015, because type 2 is the most dangerous type. And so it's very important that you are aware of this subclassification for defining your strategies. Take this case. When we talk about socket type, you can see that on tooth number 9 or tooth 21 in Europe. You can see this clearly a type 3. You almost don't need to see the CBCT to conclude that tooth number 9 is a type 3 socket type. So, but what about tooth number 8? Because it could be a type 1, because soft tissues do really look normal. It could be a type 2. If it is a type 2, what kind of type 2? What about the bone over there? So, well, when we go through the CBCT, we can really see that. In fact, we do have a type 3 on tooth number 9 or tooth 21. And we have kind of a type 2B on tooth number 11 or number 8 in US connotation. So that might help you decide what to do next. Let's see this other case. These are 4 incisors, and when you look at it, you can see that this soft tissues are normal, level, soft tissues level. Of course, they're not normal. They are inflamed, and there's probably periodontal disease in here and plaque, a lot of plaque. But the thing is that their level is normal. Soft tissues level is normal in this case. So what kind of socket type do we have here? Well, remember, it seems, when you look at it, it even seems a socket type 1 because they look normal. Okay, so when we go through the CBCT, we can see there's a medium bone loss all around. So we have, they look like, because soft tissues are normal, they look like normal, but they are really type 2. And they are type 2B because half of the buccal plate and all of them is gone. So you have soft tissues kind of disguising the bone resorption that's already there. So we should be very, very careful on this kind of thing. So remember, type 2 is the most dangerous type because clinically it looks like type 1. That's what it is. It looks like type 1. So it's wronging you about the bone because soft tissues do really look normal. So don't forget, because in terms of clinical action, in terms of implant dentistry, if you have a type 1, that's a very straightforward to immediate implant placement and immediate provisionals. So you're very comfortable doing it. It's very predictable and it's very straightforward. So that's why it's so important to diagnosis. But if you have type 2 or type 3, despite they are not a contraindication for immediate implant placement, you should know that additional grafting is going to be needed. And also you're going to have to be a very skilled surgeon and a very skilled restorative dentist to solve this kind of cases, type 2 and type 3 cases. So not a definitive contraindication to immediate implant placement, but you will have to do a lot of work more. Let's see the previous case, these two incisors, central incisors, where we have clearly a type 3 and a type 2B. Let's see what are the strategies. Traumatic tooth extraction, palatal position of the implants, okay? So these are the non-grafting strategies, okay? And the grafting strategies, you already know, GBR, soft tissue grafting, and maybe both in most of the time. So in here, it doesn't matter how traumatically you go. Of course you should go, and it's important that you go traumatically, not to damage the little bone that you already have. But traumatically or palatally placing your implant won't do you any good if you don't do a lot more than that. So in this case, we had to, this is published on Dental XP in 2013, but in this case, what we did, it was a veneer soft block into full thickness flap, and also a second surgery, a veneer soft block into split thickness flap. As I will show it in a very, very fast way, but it's in a very understandable way. So we pulled out these, I pulled out these two teeth, the two central incisors. I placed two implants at the same time. So, and I've done a surgical veneer grafting. You can see the bone grafting, all the buccal. I've used also PRGF, platelet-rich growth factors that I use a lot. Not just mixed with the particular bone graft, but also as membranes to cover all the regeneration. And as we had a very, very serious problem, as you can see, mainly on tooth number 9, and we have thin tissues. Besides doing the bone grafting, particularly bone graft, I also did a soft tissue grafting, so a connective tissue grafting, immediate implant placement, guided bone regeneration, and soft tissue grafting. So I did everything. This veneer soft block that I've collected from the palate, this connective tissue, it was put under, as you can see on the picture, it was put under the flap, and mainly positioned on tooth number 9, mainly position on tooth number 9. And I did immediate provisionals. Okay, we have a way better situation than the initial one, but we still have a big problem here. As healing goes by, you can see that there's still a huge problem. Okay, we have a nice situation of our implants. This is a very, very old case because it's, as you can see, these implants were the external eggs connection. So probably the worst connection that you can imagine. And still, you have nice soft tissues, but not enough. You still have collapse all around tooth number 9, now implant number 9. So I did a veneer soft block into a split thickness flap to increase all the tissues. So this soft block was put into this split thickness flap, and I used that to rebuild the interdental papilla, not only just the buccal part where we had a severe recession, but also to rebuild the interdental papilla into this nice interdental papilla. And this picture is 11 years after surgery. And 11 years after completing the treatment, this is how it was. And the patient smiling at the beach. So a very, very nice smile. And 11 years later, one of the most beautiful things that also I came to find is that you have a very nice bone. You have a very nice bone, and if you can see, on implant number 8, you have even less bone than on implant number 9. And implant number 9 was our biggest problem. But as we regenerated that area, not only in guided bone regeneration, but mainly soft tissues, because we really improved the soft tissues all around that area and mainly around tooth number